Okay, it is time. Sorry, I have a Ricola in my mouth because I think I'm coming down with something, so I have a little sore throat. So if you see that, my apologies. But hello and welcome. My name is Kara Moncrief, and I am the Clinical Communications Director for Sinclair. And we have a really exciting webinar today because it is a huge topic within our industry, but not just our industry, across the globe, especially in North America. So a lot of people have a lot of questions, and I see it on the news a lot that they're covering different stories, but I don't think they're covering it in a good way where the doctor is really breaking down what's going on and really giving clarity to the things that we want to know. So what I'm speaking on is semaglutide, and it is now, used to be, well, sorry, not used to be, it is for diabetes, but now it's being used kind of off protocol for weight loss. And we also want to talk about not only semaglutide and how it's working with the body and how we can lose weight from it. Also wanting to make sure it's safe, and then any type of issues that we may face as we lose weight, where we start to lose volume in the face, and therefore we start to get laxity in the face or in the neck or in the body, so on and so forth. So we'll talk a lot about this and how Sinclair's technologies compare really well with patients that are on semaglutide. So very special guest, Dr. Tacita Robertson. Her practice is really looking at things in a very holistic way, and just really giving her patients, not just giving them something for weight loss and that's it. No. So her practice is called A Greater Whole. And it truly is, that's what she encompasses, that if she is going to be prescribing this to her patients, she also wants to make sure that she's addressing any concerns that they may have with the weight loss when we have laxity to the tissue and other benefits. But she is going to be really conducting most of this webinar, and we want to make sure that we're opening it up to any questions that you may have. Feel free to unmute yourself. Feel free to write into the chat box. We really want to make it to where she's accessible to you and for your questions. Okay, so Dr. Tacita Robertson, she's going to come on now. Hello, let me spotlight you really quick. Awesome. Now you have the spotlight. Thank you so much. We so appreciate your time in doing this and your expertise.
Yeah, I'm excited. It's a great topic and all over the place these days.
Globally.
Yeah.
Okay, so I'm going to share my screen. I'll undo my spotlight, and then I'll just pop on like whenever I have questions or to add anything extra with our technology. But I'm going to share my screen really quick. Let me get your PowerPoint pulled up here.
Great.
Okay, I'm going to undo my spotlight.
Perfect. Okay. So this webinar is going over the latest weight loss trends. And I imagine most people have heard now of the GLP-1 agonist receptor medications for weight loss. They were first brought out by the drug companies for type 2 diabetes. And they were FDA cleared for that in 2017, as I recall. I'm going to go to if we could go to the next slide, that would be great. Perfect. So I'm going to refer to them as GLP-1 RAs or just GLP-1 agonists because it's a mouthful. Anyway, basically what they're doing is GLP-1 is a peptide made in the small intestine, and it helps to regulate our glucose control. So these medications are acting on the receptors for that peptide, and they are useful in treating type 2 diabetes. So you've probably heard it, in news. from pharmacies as semaglutide. That's one of the GLP-1 receptor agonists, also known by brand names as Ozempic, Rybelsus, and Wegovy. And then we also have a newer peptide that, if you haven't heard about it, you will be hearing about this one as well. Same kind of mechanism. It's called tirzepatide, also known brand name wise as Mounjaro. So I've been using both of these in my practice for patients that qualify, that have the indications to benefit from this. So kind of already covered the mechanism of action, that GLP-1 is a hormone produced in the small intestine, and the medications are acting on the receptors for that. Basically, what happens with these medications, when they're connecting to the receptor sites, they're increasing insulin and decreasing glucagon, thereby lowering blood sugar levels and stabilizing it. It's also been noted that in higher doses of these medications, there's some effect in the brain on dopamine. And so it does help to also decrease the appetite. There's also, reports in data, and I've seen this clinically, of it bringing on more focus to people and kind of making them feel more positive, again, with that action of dopamine. So there's sort of some neat little side effects, if you will, of these medications when they're used appropriately. And
I'm not sure if this is the right time to ask. Are you going to talk about the insulin a bit more? If not, I'll ask the question now.
Yeah, go for it.
Okay.
Now is time.
So I actually have a lot of questions on this.
Yeah.
So with it increasing insulin, is that something that patients that are non-diabetic, is this something that we need to worry about in someone that has the normal?
Yeah, so that's a really good question. In studies for these medications, it is noted that a unique mechanism is that they're not supposed to increase insulin and decrease glucagon unless it's in an environment where blood sugar is elevated. So that basically means that if it was given to somebody that didn't have high blood sugar, that it shouldn't be spiking their insulin and decreasing their glucagon. Having said that, if you look at the warning labels that patients get for these medications, it does speak to a potential risk of hypoglycemia or low blood sugar. So it's still something I watch for in patients, especially if someone was to give themselves too much. But technically, if you look at the pharmacology and the studies, they say that these meds were designed in a way that they're not supposed to be acting on these receptor sites to increase the insulin, decrease glucagon, unless there's a presence of high blood sugar.
Got it. And then would you avoid prescribing this to someone that had hyper or hypoglycemia, just with a risk?
Yeah, so I would be more inclined, of course, to prescribe it to someone that needs to lose weight that also has prediabetes, diabetes, or at least is trending in that pattern of having higher blood sugar, carb cravings, that kind of stuff. If someone was truly hypoglycemic, to be cautious, I wouldn't be turning to this type of medication to aid in weight loss. I don't think, there's just not as much benefit with the mechanism, and there is potential risk there. For my patients, with the way that I operate, I'm always running baseline labs on them and then doing that again, at the 3-month mark, at the 6-month mark. And I see my patients that are on these type of protocols at least every 2 weeks as well, just to be, very aware of, are they having any side effects? What does their body composition change? Because in my practice, I want to be seeing weight loss, but I want it to be fat loss, not muscle loss. Because if they're losing as much muscle as they are fat, then at the end of this, that's really kind of setting someone up for failure because their basal metabolic rate has gone down. I can say that in all of my patients thus far, I think because I do monitor them so closely and we work on education a lot, they've actually ended up with higher muscle mass at the end of their weight loss than they started with.
So, okay, this is really good. So, because I've had a lot of questions, so I'm excited about this, but sorry if I'm gonna hold it up for a minute, but so, okay, so just to clarify for people that are on here and they're wanting to maybe start prescribing this.
Yes.
So you do your labs 3 months, like pretty much every 3 months, 3 months, 6 months, 9 months.
Yeah, that's what I've been doing with my patients. So I get their baseline values because as I get further into the slides, you know, like any kind of medication, there are potential risks, right? So I always want to know, yes, okay, what is their hemoglobin A1C? So I can see what their 3-month trend of blood glucose looks like. What's their fasting blood glucose? What's their insulin level? What are their kidneys and liver doing, you know, gallbladder, making sure that those things are in check. Yeah. And
that's good to know.
Retesting.
And then seeing them every 2 weeks.
Yes.
While they're on it the entire time, this is kind of the protocol that you'll have.
That's one of my prerequisites that I am clear about. I find it very troubling, frankly, that there's a lot of clinics out there that are marking up the medication because it's very popular and hyped, and they're kind of just prescribing it, letting people lose their weight, but not really monitoring for safety and like an actual positive overall change in the person's body and how they're going to be proceeding when they're done. You know, and then in my area of medicine, seeing as I do have aesthetics in my practice, it also pairs so nicely to be doing some of those treatments, which we'll talk about more later, because it helps with continuity. You know, we can have a little chat about how things are going while doing a treatment. So yeah, we'll talk more about
I love
that.
Yeah. Love it. Okay, carry on.
Okay. All right. So yeah, so we talked about the indication. So obviously the first clearance for this drug, the purpose was for diabetes. And then due to studies, trials showing, you know, a profound amount of weight loss, it did get cleared in 2021, I believe, for non-diabetic weight loss. So it does have FDA clearance for that use. Now, for criteria for that, so we've talked about the diabetes mellitus, it can be used in those folks. And then in terms of people who maybe aren't diabetic, then, you know, you're wanting to be looking for a higher BMI. So the two criteria given to give it to non-diabetics would be people that have a BMI of either 30 or higher, or the second classification, it can be a bit lower at a minimum of 27 with at least one weight-related comorbidity like high blood pressure, high cholesterol, and they can be type 2 diabetic as well. So again, you know, I really want to emphasize this is a medical treatment. You know, it is not just weight loss, it's a medical treatment for essentially dis-ease. You know, obesity is a disease. Being severely overweight is a disease that creates a lot of different impacts in the body. So administration, so it is a subcutaneous injection, meaning it's going just under the skin. There is also one form of semaglutide that is oral. I haven't used that one. So we're focusing more on the subcutaneous because that is what is widely used and most popular. So basically a patient has either needles, you know, that they're in a syringe that they're filling up with the compounded medication, or if they're getting the brand name medications from the pharmacy, it comes in preloaded pens. They're giving themselves a once weekly subcutaneous injection into the abdomens, the thigh, or the upper arms. And I think it's important to note that with subcutaneous delivery of medication, it's a little bit slower in terms of how it's being absorbed. It's not like an intramuscular shot or an intravenous. So it can take about 24 hours for it to fully be distributed and circulating. So I just wanted to mention that kind of in the context of treatments and things as we talk further about that. So there are a number of reported common side effects. The most common ones, which I put in the slides here, include nausea, vomiting, stomach pain, constipation, definitely see skin laxity, dry skin. In my patient base, the ones that I see most frequently is definitely nausea. Haven't seen vomiting or stomach pain, thankfully. Constipation is very common because the medication does actually slow down or delay gastric emptying, which is part of that mechanism of controlling the blood sugar too. Things are being processed a bit slower. So with that, you can get some constipation. And then I would say by about month 3, month 4, as people are really, noticing some profound benefit in terms of weight loss, they're also starting to see, as that volume is lost, they can start looking kind of gaunt in the face and the neck. There's more hanging skin. Dryness can also be an issue. So this is where aesthetics can pair so beautifully to help support these patients to get an absolutely wonderful result holistically, both internally and externally. So now we're going to talk about some of the radiofrequency treatments that can be used for weight loss patients and that I've been using in my practice. So, with Sinclair, obviously we have a number of wonderful non-invasive treatments that we can do that are radiofrequency based. And the things that my patients start to bring up to me, they move from kind of there's the excitement in the first while of like, oh, the scale is going down, I'm losing body fat, things are fitting looser. And, that's all very exciting. And then they start saying, okay, well, this is really great, but I have all this hanging skin, and I'm feeling a bit dehydrated and I feel like I've aged overnight, like my wrinkles are showing more because they've lost, the plumpness and elastin has been affected and collagen has been affected, and actual hydration of the skin can be affected too, partially because they may be lacking some nutrients because this medication does decrease the appetite significantly. So the things that I tend to look at helping them with on the aesthetic end with RF include treating that lax skin that's kind of starting to hang. The abdomen, of course, is a popular area, the thighs, the buttocks, the jowl area and neck, and the upper arms would be the most popular ones. And if possible, it's really nice if you can get patients doing this alongside of the weight loss for a few reasons. If you can do it while they're on the medication and they're losing the weight, it seems like there can be kind of a nice opportunity to have the collagen making cells stimulated, the elastin regeneration to kind of be happening while they're losing that volume. At the same token, if they're not ready to do that until the end, still seeing good benefit. The other thing is skin hydration. With a lot of medical weight protocols, they do tend to feel dry. And not only does radiofrequency help with this, so like the fractional RF is fantastic. I'm going to talk even about some of the other modalities like IPL that can help with that. A unique one that I would say some practitioners may not think of is that with our V form, which has the radio frequency with a vacuum suction component and heating, that can actually help to alleviate some of the constipation and potentially even stomach discomfort that they're getting. And I also love how that therapy, absolutely improves lymphatic function. When we're losing fat, those fat cells are shrinking, right? And in our fat cells, we hold a lot of our toxins and waste products, excess hormones like estrogen. So you can imagine if you're losing weight and that is being now dumped into your system, you have to clear that. And that can potentially be a portion of the nausea people are feeling. So if you can get the lymphatics flowing and get them clearing these toxins and waste products out, it's a win-win. And it also, I feel like, helps to kind of stimulate more of that fat loss, because we are heating up those cells and shrinking them alongside of the medication. You know, and then of course there's just the self-esteem portion. It's a big transition for patients to go from having, say, a BMI of 35 down to, you know, a healthy, normal BMI fat percentage. So the last thing they want at the end of that is to feel like they now look old and saggy. And I find that they're very motivated to do everything that they can to really feel good about this new phase of their life. So specifically, now we'll talk about the V form, which I love. So kind of like I was saying, I use this one in my medical weight loss patients to really kind of help to tighten and lift and tone that lax skin. You know, often doing it in the jowls, the tummy is very popular, the thighs, the arms. And we will do it either during the weight loss, or sometimes they'll wait until after. I talked a little bit about how just the physical action of the V-form procedure in the abdomen, the heat that it's giving, the radio frequency, that can help to improve some of that peristalsis, the movement of the bowels, basically, as well as the lymphatics. So that's where, you know, we can actually kind of be helping with some of the side effects of the medication and just be getting them a better aesthetic result as well. Of course, when we're heating these fat cells with the radio frequency and shrinking them, that is promoting more weight loss and helping to get that out of their system that much quicker. And at the same time, tightening the skin. So, you know, you couldn't really ask for, I think, a better treatment or therapy to go alongside of weight loss. And it's completely non-invasive. There's no downtime. You know, patients give the feedback like, oh, it feels like a nice hot stone massage. I'm relaxed. So it's kind of a nice treat for them. And then again, I use that time wisely to just check in on how they're doing, give them encouragement. So it keeps things nice and consistent. Also just mentioned on the PowerPoint at the bottom there that you can be doing some contouring with the V form. So of course we can tighten and lift, but with the V form, we can be doing some contouring. So maybe they've lost a good chunk of weight, but there's a couple pouches somewhere, maybe it's on the thighs or the butt, or under the chin that they want to contour more. We have the ability to do that as well. And then IPL. So I snuck this one in here, even though we're talking more so about radio frequency. I more so use this to kind of be helping with the overall tone of the skin and also the hydration. So I have found that when we do IPL, whether it's on arms, the face, the neck, the chest, you know, it gives this really nice plumping, hydrating effect because of how it's affecting the cells, stimulating the mitochondria, stimulating collagen. So their skin will plump up quite quickly. At the same time, as they're going through changes with their hormones and the weight loss, sometimes pigment can be showing up more, or with their face kind of involuted and getting more wrinkly, that's more of a problem. So again, doing, you know, a photofacial type of protocol can be a really nice way for them to get a quick uplifting, you know, boost in how they are feeling about themselves, but also what they see when they look in the mirror. So I think that IPL is another really good one to add in. And I like using it on a lot of different areas of the body, to be honest, because it has such great, quick anti-aging results and it's easy to do. And then VFR. So this has been my new favorite one. So this is the fractional radio frequency. So definitely a heavier hitting type of radio frequency technology. We have the ability to do a more shallow treatment with ablation. This can be very helpful with dry, flaky skin, also getting off wrinkles, pigmented lesions, things like that. And then we have the medium and the deeper treatments, which would be geared more towards moderate to deep wrinkles, scars, things like that. Stretch marks too. I mean, stretch marks are a huge thing that appear when people are having significant weight loss, and it can leave them feeling kind of just deflated, literally and figuratively speaking, because they've gone through this process, they've lost this weight, and then they have these unsightly stretch marks. So I really like using the fractional RF for that. It works very, very well. And people have been happy with that. The other thing, is actually next slide, sorry. We go to the next one. And then I just mentioned too for the VFR that's obviously excellent for face, neck, body stretch marks, etc. So kind of leaving it open after this to discussion. I'm more than happy, to talk about real life clinical results I've had with patients in my practice, some of the customized protocols that I've put together for my patients who are going through medical weight loss, specifically semaglutide and tirzepatide. So I'm happy to answer any questions about that or anything else.
I'm going to give it a second to see if anybody unmutes. And then if they don't, I have I have a list of questions for you, but I'll give it a second.
Yeah, absolutely.
I have a quick question.
Chancellor. Oh, we all do.
Sorry, go ahead.
No, thanks, Chrissy. Hi, Dr. Chancellor. It's Devin. That was such an amazing presentation, first of all. But my question for you is, how do you feel about the use of GLP-1 agonists for the use of weight loss in PCOS patients?
Yeah, I think that can be a really good fit, because with the PCOS patients, one of the cardinal things with that is blood sugar dysregulation. So often patients with PCOS are put on things like metformin, which can tend to be, kind of hard on the kidneys and liver and has side effects. So yes, I would say that it can be a really good fit for those patients.
Thank you.
Yeah.
So my question, I'm just super excited about the whole thing, and I love that you're testing every 3 months.
Yeah.
In practice, I think if people move, from like a 8 A1C to like a 7.8 in 3 months, that's very exciting. What kind of trends are you seeing? Like, what's the improvement?
Yeah, so I would say maybe contrary to what media hype shows, it is not an overnight solution. So patients who, are pre-diabetic or diabetic, they're often on this for at least 6 months, sometimes closer to 9 months. And it is a slow progression. We absolutely see it coming down, but it's not just overnight or in 3 months. But definitely, like with my pre-diabetic patients, say if they're at like a 5.8 or 5.7, they're coming down to like a 5.2 or a 5.3. That's been my observation, my patients. If you look at the studies with semaglutide in diabetics, they're often still in at least a pre-diabetic level, with treatment, but it certainly improves. Does that answer your question?
It sure does. Thank you.
Yeah. And again, with that too, I would just say on, kind of the broader scope, while I'm going through this with patients, aside from giving the medication and monitoring their labs, we are talking about food choices and portions of food. And, many of them are seeing a psychologist in my office alongside of that, if there's, thought patterns and things that have led to their obesity. Sometimes it's a straight medical endocrine thing. Other times, you've got those other components. So I think it's always good to look at all those factors.
Absolutely. I think your patients are lucky to have you.
Thank you.
I had a quick question. It's Aaliyah, by the way.
Hi. I can't see anyone's face.
I'll hop on for you since I'm ready and everything. So thank you for this. This is amazing. I've been on semaglutide for like 6 weeks and it's been life-changing for me. I love it so much. Yeah, I've seen online, kind of varying opinions. I've seen people say like, we will not prescribe the compounded version of semaglutide, like only the Wegovy and whatnot. I was just wondering your opinions on that.
Yeah. So in my practice, part of what I do aside from say weight loss, that's one thing, but I do a lot of bioidentical hormone replacement therapy. So by nature of that, I work with a number of compounding pharmacies that I trust. And so when I initiated this therapy I've used a lot of compounding pharmacies for the semaglutide and tirzepatide for a few reasons. One of them is that the cost benefit that we can give to the patient is helpful because it becomes a very expensive therapy as you move up in the doses each month. So that's one factor. But the other thing is, the quality, again, you have to know your compounding pharmacy. The quality has been very good. And sometimes they will be able to add in some other things like B12, for instance, which can be supportive. Or one compounding pharmacy I use adds in another peptide that actually helps to offset some of the GI side effects and also happens to be good for joint tissues, which if you're looking at someone who's been obese for a long time, they often have degradation of their joints. So that can be a nice fit. So I would say that I would disagree with only using the brand name pharmaceuticals. I would put an asterisk to that and say that any provider using a compounding pharmacy needs to make sure that they're familiar with that compounding pharmacy and their quality and products.
Awesome. Thank you. Perfect.
Yeah. The availability with compounding pharmacies too can be beneficial as well. I have definitely seen patients of mine getting it from standard pharmacies and running into issues with shortages, which is definitely an issue with this class of medication these days, with its use expanding.
Any other questions from anyone? I have a list, so I just want to make sure.
I have one more question that I just came up with, Dr. Chancellor.
Yeah, absolutely.
Awesome. So I read a paper recently that showed that there maybe was a greater % weight loss in patients who were on, a Mounjaro regimen compared to Ozempic. I just was curious, in your practice, you said you're utilizing both, like kind of like what you see in terms of that. Like, is that holding true?
That is actually what I have seen clinically. I started out using semaglutide, and when tirzepatide became available and I'd learned about that, I heard the same thing and I thought, okay, well, we'll try it out. And I actually switched some of my patients who had been on semaglutide for some time onto tirzepatide. And you have to make sure you get the dosing right with that, by the way, if you're going to do that. But I did actually find that each one of those patients reported much less nausea, and they found that their appetite control was even better. So I would say, clinically speaking, at least from my cohort of patients, that has been true, that it is actually a little bit more effective and fewer side effects. So I am starting patients out on tirzepatide now more often than not.
Wow, that's great. Thank you.
Yeah. Yeah. Yep. It helps. Nausea is definitely the most common thing that people kind of struggle with. And, it varies from being just very, very minor to like, oh, I'm feeling pretty nauseous and we need to do something about that. So to be able to lessen that side effect is really nice.
All right. Anybody have any other questions? If one pops up, of course, you can always unmute yourself. That was so amazing. I know we're not done, but
Yeah.
so good and so informative. Okay, so I have a list. So you were speaking on muscle. Is that a possibility of being on and losing muscle mass for some of your patients?
Yeah, I mean, absolutely. That's always, I always consider that a risk factor of any kind of weight loss protocol, but especially when you're doing, medical weight loss where there is a big component of appetite suppression. Patients will report back to me like, Dr. Tassida, I opened my fridge, like I normally would, to go and get the chocolate I liked or to get a glass of wine, and I opened it and I just felt like completely off put by the thought of eating or drinking. So these people's appetite goes down significantly. So they're taking in less food, which means that their basic requirements to maintain their existing skeletal muscle, could be depleted if they're not getting enough protein and whatnot.
Yeah.
So again, I always get my patients on a body composition scale to see, all right, what are we starting at? Like, what's our hydration level? What's our lean muscle mass? What is our fat percentage? And then I'm monitoring that because, I definitely will see at some points where people have started to lose a little bit of muscle. And then I'm counseling and saying, hey, remember, at the end of this, your metabolic rate is based on how much lean mass you have. Okay. So we really need to make sure we get a handle on this. We need to be eating a little bit more. So even if you may not feel like it, we're going to have a protein shake. We're going to do this. And then also encouraging them to be challenging their muscles. So to be doing movement that is putting stress on the muscles so that, again, they're keeping up with that. And most of my patients so far have come out actually with more muscle mass at the end of their weight loss than what they started with, which is quite extraordinary because typically it's like part fat loss, part water, part muscle.
Yeah. It's so interesting. Okay, so that leads me actually to more of my questions. Is it okay for them to continue like their full physical, working out, playing sports? Do they still have that same like drive to do those things for most of your patients?
Yep, for most of my patients, they do. And for the ones that don't, that's again something I'm hitting home on those, bi-monthly visits is like, okay, so what are you going to try? What class are you going to go to? What are you going to do? Like we got to get moving, because my goal is always that at the end of this, they're going to have a long lasting result.
Mm-hmm.
And if you look at studies on this medication, it can be, kind of sad to see that a large percentage of patients can gain weight back after. But what these studies are not taking into account is proper monitoring and counseling throughout the process. Right. None of them are taking that into account. The other thing I would say too, just a little kind of clinical pearl, is I spent a lot of time talking to pharmacists, doing research about ways that once a weight loss patient has gotten to that goal, how to get them off of it. Because typically prescribers will say, okay, well, you're done. So good job. Go live life. Well, that's a pretty scary thing for people who have struggled with obesity, that have gone onto a medication that suppresses their appetite, that now they're off of it and the appetite has come back roaring. That's a very uncomfortable place for them often to be in. So I actually titrate my patients back down, and we continue to discuss, the psychology behind how they're feeling as that's happening. And reinforcing all of the great things that they've learned and the tools and how their biochemistry is now different than it was before. So it's sort of reprogramming them to better understand that, they're not the same person that they were when they first started this, both, biochemically and mentally, that they can be set up for success basically long term.
I love this. I love that you've thought out everything because a lot of offices haven't, right? And it's like, well, it worked for me, but now it didn't work for me because everything's back. I love the approach that you take.
Yeah, well, I think, for many people who have struggled with weight for years and years, they've tried a number of things and they've lost weight only to gain it back.
Right.
And be in a worse situation because the underlying things, whether it was hormonal, physical, mental combination, those things weren't addressed. And I think it's frankly cruel to take somebody through a protocol like this and then just leave them hanging.
Yeah, absolutely. Rachel, if you want to unmute yourself, you can ask or you can write it in. It's up to you.
Well, thanks for that. I appreciate it. I just wanted to say thank you because I'm a health coach. So I do see a lot of people that are on GLP-1s.
Yeah.
And I think it is completely undervalued, right? This concept of, behavior modification, because that's ultimately what's going to make it last, right? So I just wanted to say thank you for that. It's a plug for all those health coaches out there that are,
That's great.
helping facilitate some change in some more long-lasting ways, with the help of these medications. So thank you for what you're doing.
Thank you for what you're doing.
I love that. Okay, so the next question I have, alcohol. I know that it suppresses the craving. One,
Yes.
do you know why? And then have they done any papers on that? And then two, are they allowed to drink on the medication?
Yeah, so I need to research the mechanism behind that more myself. I have not yet seen anything directly researching that. Maybe it's out there and I haven't found it yet. Just myself thinking about the potential pathophysiology in that, I would say that, again, like I said at the beginning, as people are getting onto the higher doses, it was noticed to be affecting some centers of the brain, like our dopamine levels, which is, kind of a reward, and it affects the satiety and the mood. I've even had people who had a little bit of kind of attention deficit type symptoms improve on this medication. So I think that perhaps with the alcohol piece, that maybe that kind of reward center that was lighting up with the alcohol is already being stimulated. So the drive for alcohol maybe just isn't as much there. And then the other piece of feedback that I've heard clinically is that, like, there was one patient of mine, she's done phenomenally well. And, kind of a tradition with her husband was they'd have a glass of wine in the hot tub and talk about their day. And that was like really special. And she's like, I just can't have it. She's like, even if I try to just to take it in, like, it just doesn't feel good to me. And they also report saying that a lot of the higher fat foods don't feel good to them. So there's something else going on there too. And, alcohol essentially to our body is sugar. So it's going to be stimulating the blood sugar to go up, which is then going to stimulate this medication to kick in and do its thing, which then can lead to nausea. So I kind of think it's like some complex feedback loop.
Yeah. No, that really makes sense. If are they allowed to drink on it, or should they avoid?
I tell my patients to avoid it. Technically they can have a little. There isn't anything saying, it's absolutely contraindicated, you cannot have any. But I definitely would caution against having more than a very minimal amount. It's not, not doing any favors for what they're trying to achieve.
Yeah, for sure. I figured that, but I wasn't sure if like someone was like, I really want a glass of wine. Am I allowed? That's good to know. Okay. So what I absolutely loved is when you spoke about one, dryness to the skin. And then another one is working with lymphatics in the bowels. So I wanted to talk about that a little bit more. With dryness, does every patient experience that, or is it just kind of hit or miss that they'll have dryness to the skin?
I would say in my practice, about 70% of people are bringing that up. So maybe it's not every single patient, but it definitely has been a pretty common theme. And I think part of it can be they're taking in, less food overall. So there may be some lack of essential fatty acids happening. There may be, just a lack of calories in general. I always, tell them to drink lots of water and still get in the healthy fats and things like that. But yeah, it's a common complaint that I'm hearing.
Mm-hmm. That's good to know, but we have a solution. So I was so
Yeah.
excited.
Yeah.
I mean, I wasn't excited to hear that people had dry skin. Of course, that's unfortunate, but that we do have that solution to help with dry skin was phenomenal. So I'm so happy that you spoke on that. And then especially with the percent of people that's suffering from that. And then also, I know that it can be a risk, I think, of like bowel obstructions and things like that. So I love the fact that you can sell it as a package to never have to get into that scenario where they're going to have the patient or leading to like major issues.
Yeah.
Selling it with the V form to make sure that we're keeping up with their bowel movements.
Yep, absolutely. And with, the V form, it's nice to be able to do that on a weekly basis or, pretty close to that, which again, it's like helping to keep that practitioner patient communication and relationship going as well. But yeah, it does practically help with some of those side effects. So it's
so good.
Great. Yeah.
And I know it's like lower risks, but it's just so nice that we have that solution. And then go ahead.
There was one thing I wanted to mention that someone had asked me a few weeks ago with regards to the V form and the fact that these medications are a subcutaneous injection.
Yeah.
That question that was posed to me was, if someone, has had a recent injection, can I treat them? And so with subcutaneous medications, they're a little bit slower to absorb. It can take up to 24 hours. These medications also have a very long half-life of about 7 days. So they're in the system for a long time. So what I would say in response to that is, okay, example, say I'm doing a V form treatment on my patient and it's the abdomen. I would be saying, all right, seeing as we're doing a series of treatments on this, when you take your weekly injection, please do it in your upper arm or please do it in your thigh. So that I'm not locally going right over where that medication is potentially still, absorbing and being delivered. But it's not an absolute contraindication that because someone's on a subcutaneous medication that they can't have a treatment. I would just use a bit of, common sense and caution as to, all right, where'd you have that injection? And let's let it do its thing.
No, that's really good to know. Can they, in the same day would be fine as long as it's not in the same area, right?
Yeah, I don't see a reason. I mean, it shouldn't be disrupting it. And again, they're kind of a slow absorbing medication and in the system for quite some time. So
yeah. I think just a couple more questions. So I was just curious, what is the length that someone should be on this medication if they're taking it for weight loss? Like, would you say that there was kind of a cutoff for them, a year or?
In the case of weight loss, I mean, I don't have a definite, okay, you cannot be on it for longer than this amount of time. So again, it's sort of this practitioner patient judgment call and monitoring. You want to make sure that they're not heading in the direction of some of the more major side effects like gallstones or pancreatitis. I've never seen that in my practice. I've had patients on it for up to 9 or 10 months. Those have been ones that have a very profound amount of weight to lose. And then again, I'm easing them off of it.
Mm-hmm.
But in general, I'd say most people are on it for around, up to 6 months. But it is sort of a case by case thing. There are people who, I have definitely looked at the data that are on this medication long-term for diabetes. That's not a huge bulk of my practice, so I can't speak to that as much as maybe a diabetic specialist could.
Yeah. I'm so excited because I mean, I told you like I was a little skeptical because I'm just unsure about it. But what like puts me at ease and really excited about it is I think the side effects I've heard from people are the ones that have needed to take it for diabetes for a very long period of time. And hearing that we can get that great response with the body in about 6 months and taper off of it is it's game changing, right? It's amazing.
It is. It's really game changing and life giving to, the people who are able to turn their health around. Because
Mhm.
it, again, it's like it's not just losing weight. It's treating hypertension. It's treating high cholesterols. It's treating inflammation and joint pain and self-esteem, all kinds of things. I could go on and on. So
Yeah, no, it's so good. What are the typical hormone changes that you see visually? So you spoke on, of course, when we have hormone fluctuations, we can have pigment issues. But
right.
again,
Yeah.
we have something to fix that, which is
Yeah.
amazing. Is there anything else that you've seen with hormone changes with it?
So what I'd be speaking more specifically to with that comment, so I do a lot of in-depth hormone testing with my patients, right? And monitor estrogen as well. And I usually do that via urine, by the way, in case people are watching, because with our estrogen, us women fluctuate a little bit from day to day. So blood is sort of giving a snapshot. So I do blood and urine testing. So with regards to fat loss, when we're storing a bunch of extra fat cells, we tend to have what we would call excess exogenous estrogen. So I have seen this a lot in my patients because fat, like extra fat, actually acts as its own endocrine organ. This is what a lot of people don't know. It is spitting out extra estrogen and cortisol and all kinds of stuff. And so when you've got that excess estrogen piece, for instance, and then that's coming down and changing, we will sometimes see changes in the pigment, and changes in the texture of the skin, just like, some people may notice throughout the month, right? For a menstruating female, that sometimes pigment looks a little darker at some times of the month, and then other times it's lighter, kind of a similar concept to that.
I love this. So then in my brain, I'm thinking this is great with the V form and vacuum and RF, all the heat and like detoxing the body, right? Just get it out faster.
Yes. Yeah. And I would argue that for some patients, that report nausea or stomach pain, some of it for some of them could be based on that detox reaction. Because I mean, when I take people through detox protocols that aren't trying to lose weight, they'll have the nausea, they'll have fatigue. A lot of things can happen when we're releasing these waste products into our bloodstream, which is exactly what's happening when we're losing fat.
Oh.
Yeah.
So I think my last one, and then we'll wait a second and see if anybody else has any. Do you want to share any of your like special packaging that you may sell to somebody that's wanting this? Maybe something that's not even Sinclair related, but just things that really go together in conjunction.
Yeah. So the most common things I would do, I am a big fan of combining multiple modalities, because I just feel like, I don't know, tend to get a better result. But so a common one would be, doing a package of V form. So it could be 6, it could be 9. Sometimes we'll start out at 4, and I'll manage expectations saying, you're going to most likely need several more than this. But I really like starting out with 6 to 9 and trying to do that about every 7 to 10 days. And then often we may throw in, maybe like 2 or 3 IPLs with that as well as part of a package, so that they can also be, kind of getting that hydration in the face and the neck, dealing with pigment, or if the concerns, especially for some of the older patients that have been heavier longer, if laxity and wrinkles are more of a thing, then I really like doing a series of 3 of the fractional RF. And if people have something like Dermafuse as well, that's a really nice booster for hydration and collagen and all that kind of stuff. That also can be used, on the tummy and the thighs. So that would be another, I didn't put that in the slides, but that's another nice modality that's getting some lymphatics going as well. And the price point for some people might be a bit more manageable. But yeah, I would say at least a series of V form, and let them choose the region that they're most interested in. And I found that often then they're like, oh, well, I want to do this other region too. And then this other one and this other one. And what I've seen quite a bit of is when people are getting close to being done the medication, that expenditure that they were putting towards the medicine, because it is expensive, they're now wanting to put towards how they're feeling on the outside. So that's been really common in my practice anyway. They're like, okay, well, now that I'm done with that, let's work on it.
Yeah, and then it just like spirals.
Yeah.
I would think, as you're talking, I'm thinking of other things. So I would think starting with the face right away, right? So it doesn't get so gaunt, and it's a slower progression of, okay, like I kind of see a little laxity, but it's not so bad because you started right away.
Yeah.
I love that. And then you brought out the Dermafuse, the lipo-LM.
Yes.
That would be amazing. So you could do the V form on the abdomen, then use the lipo-LM. For those of you that may not know, it's a serum that helps break down the fat even more. So it's just an additional booster. I feel like that would be a really good one as well.
Yep, totally. I like that one. And you could always pair it too with doing the hydrating serum,
Yeah.
collagen boosting serum. So
that one's really good because Dermafuse is quick and easy, and it's so good with hydration that could just be done on a weekly basis. So they really don't suffer from that dry skin.
yep, absolutely. Yeah, I like that. That's a good one.
And then something that I thought of, just wanted to get your thoughts. So, postmenopausal, when our estrogen just depletes, and you have the and you have you have the VVR, so the intravaginal. And then us women, we suffer, when we go through menopause, dryness and laxity and so on and so forth. And it's because the depletion of estrogen, I would think if they get on this medication and you're using the V form and all that estrogen is kind of like moving throughout the body, that would almost be a perfect time to start VVR if they need it, because it's even more estrogen flow to the tissue. You may get a better response.
Yeah, I think that's a good line of thinking. And again, it's like, while everything's moving and changing, to be getting that RF treatment in that tissue, so that it can be adapting to the changes that much better, makes sense to me.
Yeah. Just thought of that. I was like, that may give a really good response. Well, thank you so much. Does anybody else have any more questions before we sign off? We'll just give it a second. I don't see anything in the chat. Nope, nothing in the chat. All right. Thank you so much. Like I cannot thank you enough how informative this was. You completely changed my outlook on everything. I can't wait to talk to everybody, every office, about how it pairs with our systems. Yeah. You're such an amazing speaker. You put it in a way where you can really understand it. And you also put it in a way to where all of us on here, if we want to do it personally, to look for the right doctor, right? Look for a physician, or if you guys are on here are a physician, doing it the right way to make sure that your patients are really happy. So I can't thank you enough for all of your education on this.
Well, thanks for the opportunity to be here, and I hope that it's helpful for lots of people down the road too. So,
oh, I'm sure it is. I so appreciate it. I really hope that we do a webinar in the near future. It was such a delight.
Thank you, Kara. All right.
All right. Thanks, you guys.